Hi, we are going to do IV start in lab today. So what I'm going to need is my patient, which will be our mannequin arm. I'm going to have a chucks or a towel, something I can put under the arm in case I make a mess. I won't have to change their bed. We need a tourniquet. I need a ChloraPrep sponge or something I'm going to cleanse the skin with. I need my angiocath, which is going to actually establish the IV. I need an extension that I'm going to put on the end of my IV so I don't have to put stress on insertion site. I need a flush syringe because I'm going to check that I have blood coming back and flush it to make sure there's no blood in my extension. I need a dressing and tape and a pair of clean gloves. Now, depending on where you're going to do this skill, you may have an IV kit already prepared with these items in it. If not, usually there will be a bin that is designated for IV start supplies. Why I'm mentioning that is because the tape that you use, if you choose to use tape, you want to make sure that it is clean tape and that it hasn't been in your pocket a long time or taken from room to room of your patients. So to get started, I'm going to put my chucks under the arm of my patient, or my towel, whichever you choose to use. And I want to assess where I plan to initiate this IV. Remember, by reading your study guide, we want to go more distally to start, because if something were to go wrong at that site, we could still work up the arm. Take into consideration your patient's preferences. Are they right-handed or left-handed? And any problems they may have. Do they have an injury to one side or the other? Did they have a mastectomy? And so there are some reasons you wouldn't stick on one side or the other. So you're going to make those decisions, and you're going to select where you want to stick. Then to assess the site, we can put our tourniquet on. We put it on about 3 to 4 inches above where you plan to stick. And the way I do it is I put it around the arm and I pull on the sides and just loop under and secure it. And then I'm going to look to see where I'm going to stick. And I'm going to stick along this vein right here. And then I'm going to release the tourniquet until I'm getting ready to stick, so as not to injure my patient while I set up my supplies. Tying the tourniquet, I usually think of it as if you do a pigtail and the last one through, you don't go all the way through. You want to make sure it's a quick release so you can get it unfastened quickly. Then I'm going to set up my supplies. So I need my ChloraPrep. I'm going to open that because I'm going to use that to cleanse the skin. I'm going to get my extension opened and make sure that things are secured. I'm going to get my flush syringe, and if I just got it open, I'm going to make sure I bump the air out of it. And then I'm going to attach it to my extension, and I want to flush this to get fluid in there. And I like to either loosen or take that cap off and put this back in its package so it's safe, because I'm going to need to fumble with that once I get my sites initiated. I'm going to open my dressing and put that where I can get to it.
Dr. Pilon, why do you put it back in the container?
So that it stays safe and the end that I have uncapped does not touch onto a dirty surface.
So you're keeping the end of it sterile?
Sterile.
Either with the cap or by putting it back in there.
Right.
Okay, perfect.
So if you want to keep the cap on, it's just when you get to the place where you're going to use it, you don't want to have to fumble with fighting to get that cap off when you have blood coming out of your IV. So I choose to take it off and put it back in the package, but you want to ensure that that end of your extension is kept sterile and clean. So I do that by resting it back in that package.
Gotcha.
I'm going to prepare my tape. I always state in lab that tape is controversial. Some places you will be instructed not to use tape. I like to use tape because I think it secures it better. So again, if I'm going to use tape, I want to make sure that it is a clean, fresh roll of tape that is used for IV starts. I take one piece, about 2 to 3 inches, in half, like we did when we did our NG tubes. I'm going to put it on my table next to me so it's handy, and then just another piece about 2 to 3 inches, not cut in half, and that's going to use to secure my extension once I get it in place. So again, I'm setting everything up so when I'm ready to go, I have it all available to me. I'm going to open up my angio-cath, and I'm going to show this to you before I use it, just so you can see what's going on here. So this is an example of an angio-cath. They come in different sizes and gauges, just like our needles did when we did injections. You take it out of its protective sheath. It has a handle, which has little indents where you're going to hold it. You want to hold it from above because you're going to go at a shallow angle, 5 to 15 degrees to your patient's skin, so you don't want to hold it from underneath or your hand will get in the way. So you're going to hold it from top. There's this white button. We're going to use that in real life to engage the needle after we stick to go into this sheath to disappear so we don't get a needle stick.
Can you? Yes. I'm going to zoom in on that for a second. Okay.
This is your angio-cath. This part comes off of the needle. So this is the needle you're going to use to establish your IV. And when you hit that white button, it goes into this capsule. This is a flexible lumen. It's made out of plastic, and that's what stays in their arm to keep your IV intact.
Don't do that at home. Okay.
Yeah, don't do that now, but we're going to show. So I'm going to put that back together so when I need it, I have it. Okay. So now I've set everything up, so I'm going to get started to establish an IV on my patient. I'm going to put on clean gloves. This is not a sterile procedure, but as we have learned in the past, when using materials, you're going to keep your materials sterile because they're package sterile, and we are using them on a patient. But we're going to wear clean gloves. I'm going to retie my tourniquet. And then I'm going to get my ChloraPrep. And this, when you shake it, you can hear there's a little capsule in there, and in real life I would squeeze these wings and it would break that capsule and get my sponge wet. So you may do that in real life, but I'm just going to pretend with my mannequin. To cleanse my area where I plan to stick, I'm going to go over and around it in a larger area, and I'm going to clean for 30 seconds. So this will be twice as long as we scrub our hubs when we do things with our IV lines. For skin, we're going to clean for 60 seconds. No, is that right?
It's 30, right?
30 seconds. 30 seconds. I'm confusing myself. So 30 seconds, I can watch a clock, or if I had a watch, or count. Got a nice big area around where I plan to stick, nice and clean. So I've cleaned for 30 seconds. Get rid of that. And now I'm going to get ready to stick. So I'm going to get my angio-cath, take off my cap. I'm going to hold it, bevel up, so when you look at your needle, you'll see the bevel. I want bevel up. If it has wings, you want the wings down against the skin. I'm going to hold it by those little indents on my handle. I like to secure the skin of my patients by, with my thumb of my opposite hand that I'm using to initiate the IV, of pulling back on the bottom of the vein. Some people will hold above and below. However works for you is fine, just do not touch the area you plan to stick. So I'm going to secure my vein, hold my angio-cath, hold it at a shallow angle to the skin right over the vein, and insert. Once I get it where I think that I'm in the vein, in real life you should have blood coming up through your angio-cath under your white button. So now I'm going to freeze this hand, and I'm not going to advance my needle any further because I don't want to go through the vein because the vein is very small. So I freeze, and then I take my other hand and I thread that angio-cath off of the needle into the vein, all the way up to the hub. And then I could hit the white button, or I'm going to take it out just so I can reuse this for practice. And I'm going to hold pressure right above where it's inserted, get my extension, and put it on there because blood will be coming out of there. Once I have that secured and no longer blood dripping, I'm going to release my tourniquet. You want to release that as soon as you can to give your patient some comfort. So once I have my extension on, There still should be some blood coming back, but I'm going to pull back on my syringe to make sure there's blood coming out of the vein, and then I'm going to flush it. When you flush it, it should flush very easy. That means you're in the vein. If it's got resistance or you can't push the plunger easy, then you're not in the vein. So you're going to have to start over. Typically, you're going to flush with 2 to 3 milliliters. I just did the whole 10 mLs, and then I'm going to remove my syringe so that's not pulling on my catheter. And now I need to secure it. So I choose to take a piece of my half tape and put it underneath my IV wings and chevron it over those wings. Now, as I said before, some facilities may caution you not to use tape, and if you do, make sure it's clean tape. My second half piece of tape, I'm just going to put over the blue hub to secure it under there. So as you can see, I have inserted the IV and secured it with 2 pieces of tape, one sticky side up over the wings, and then a piece across that blue hub. And then I'm going to cover it with my Tegaderm. And I like to put the insertion site centered in whatever size dressing I have to protect insertion site. That is your site that goes directly into your patient's bloodstream, so you want it to be safe and secure. So I like to center it in my dressing. And it may or may not come over the hub. If it does, that's fine. If it doesn't, that's fine as well. It's going to depend on what type of angiocath you're using and your extensions. Your dressings have a little sticker on here, and I would write the date, time, and initials, and so people would know when and who established that IV. Put it right over top of the Tegaderm. And then my third piece of tape, I like to just secure the extension to their arm off to the side. So this is whenever I need to initiate any medications or flush or check this IV, I'm going to manipulate this extension. I'm in this cap and not the insertion site, so I don't jeopardize and pull at the insertion site, is why we're using extensions and we're securing it with tape. When you establish an IV, you want to pay attention to what your institution's protocols and guidelines are and how long we can keep an IV. If it does not have an infusion, you want to at least check it for patency and flush it every shift. And you should be able to keep IV up to 5 days if it is not causing problems and it is still patent and usable. And you can change it PRN. So if they need a new IV and the time has not elapsed, you can go ahead and change it. Again, look in the literature. That is something that is always being reviewed. We used to take IVs out every 3 days, no matter what, if they were good or bad. And now the literature is going more towards a direction, as long as it is not causing discomfort or pain to your patient and it is still patent and viable, you can continue to use it. But pay attention to your institution. So I have this established, and my patient has got their therapy.
Now, Dr. Pilon, what's that little blue thing?
Oh, this little blue thing? That's a lock on the line. And so I could slide it closed, and that would just prevent any blood to come out of the vein or anything to go into it. So when you're going to utilize your extension, make sure your lock is open, because it may prevent you from using your IV. Sometimes after you flush it, you can lock it so blood doesn't come back, because sometimes patients will say, ooh, there's blood in my extension. And really that's fine. That means you got a good vein. But to prevent that, you can flush it and lock it, and blood shouldn't come back. But that's just a little lock just to secure there's no movement in your extension tubing when not in use. But if you're utilizing it, make sure your lock is open. So if I have done everything, whenever this patient say this time for them to be discharged, and we're going to remove the IV. So I'm going to put on clean gloves again, come back into my patient's room, and explain to them that I'm going to remove their IV, and we're going to take off any tape that's on them. And when you remove the tape around the insertion site in your Tegaderm, make sure you secure your IV so you don't just rip it out, and pull your Tegaderm towards the insertion site. And Tegaderms, as we have noticed when we were in wound care, are very unforgiving, so they just pull and bunch all together. And then if I have any tape underneath, I want to loosen it before I pull my IV out. Once I have all tape removed, I'm going to pull the IV straight back out of the vein, and then I should have a gauze. I can hold pressure over that. Depending on if they were bleeding, you can hold pressure for 30 seconds to 2 minutes, and if they need to have a Band-Aid or a gauze, you can tape it in place for a while just so it doesn't continue to bleed. And then you're done with IV insertion and removal.